And yes, so I had the chance to present my work because I don't know if you've heard of the George Institute within the School of Public Health, and I've only just joined 1 year ago. So I do health systems research. I work on pandemic preparedness and other emergencies, but I do use methodologies that are a bit different from the ones that Imperial College normally uses, more quantitative, modeling. So I thought, I really want to, as Tim said, what are you going to cover? I wanted to cover everything I've done in my career, but then I thought, okay, I've only got 20 minutes, I think. And also, I've only just learned that people only remember around 5% to 10% of what you mention in a talk. So I was like, oh, wow, so what do I do then? So I thought I'm going to put my key messages in the title, which I've never done before, and I hope it works. So the question is, and I think it's what we're covering today, actually. Are health systems more resilient to emergencies? So the answer is no. And then I'll explain why. And then some hope in terms of what we can do. And the approach that I'm advocating for is through systems thinking. So we need to think of a different way of thinking of health systems as building blocks. I was also very glad to hear from the previous speakers the word of co-production. We need to co-produce with communities. We need to break the silos in health systems, and now I will explain how I've been trying to break the silos in the field of health systems. And above all, at this point, we need to engage actually with policymakers and politicians and make them listen to us, which is not the easiest. Like when you see photos of cabinets, normally the Minister of Health is hiding at the back. So that makes you realize that we don't tend to be a priority. So I think we need to think of new ways of engaging so we are more listened to. So these are my key messages, but now into the talk. So to situate a bit, before we go into health systems, of course, I wanted to give you a sense of the global context. And we are not doing very well with the Sustainable Development Goals in terms of universal health coverage. The figures here are quite staggering. I think the key message to emphasize is that right now, we are off track on SDGs by 2030, and you can see the countries in red and in yellow and orange. But we still have, my kind of message of hope is that we still have a few years left. And if we try to push in terms of political commitment, and if we can all work together, I think still maybe not to completely fulfill the Sustainable Development Goals, but improve the previous slide that I've showed to you. And here we have an example of the high-level meeting that happened in New York last year. And this is the areas where I think as academics, we also need to try to fit there. And they organize side events, like the same that you have the World Health Assembly. Sometimes we forget a bit about New York. But in these meetings, it's also a good way to influence and to organize and to present our research. And here what was clear is that we are lagging behind in terms of UHC. But one very interesting concept for those working in primary healthcare. Now the new mantra, the new buzzword is that we're going to achieve UHC through primary healthcare. And this, you will hear Tedros, you will hear ministers mentioning this. Still not clear how to do it, but for those that we work in primary healthcare, it's a very good message. And finally, I think what is very clear here is all the interconnections that I said about breaking the silos. We need a convergence on equity as a value, gender equality, climate change, health security, innovation, and digital health. So now moving to the global level, to the work that I've been doing all these years, and as I said, I'm going to go quite quick because I've got lots of slides. So the idea is that maybe I will not spend a lot of time with each slide, but then you can have a look at them because I wanted to put all the papers, all the research, because it comes from completely, I think, a bit of a different angle to what you've been used to. So first of all, this is work that we've done. We started already in 2015, starting to work on what do we mean by health systems resilience and how do we respond to shocks. And here always the idea is to bring different expertise together. So in this paper, it was one of the first papers where we linked migration, we linked climate change, and we also linked Ebola crisis, and we also linked austerity measures. So we tried to bring all these crises together, and what were some of the key components that we needed to take into account. So you see there that for us it was key, once we all got together all our different expertise, health management and information systems were key, health funding and financing, and the health workforce. But above all, and sometimes we forget when we talk about the software of the health system, the values within the system. And also, really a cross-sectional component is governance, and I will say a bit more about that. Then I forgot to say that before coming to Imperial, I was at London School of Hygiene for many years. Then I was at Singapore for 7 years. So for me, it was very important to do work in health systems in Asia and bringing together experts in the region. And I wanted to move from resilient, and here's with the to people-centeredness. So when we talk about resilient health systems, for me it sounded very like we're only thinking about the system. How do we make it strong? And what about the people within the system? So I started kind of conceptualizing a bit different and trying to bring these two areas together. And then WHO came to some of us that we work on health systems and said, okay, the health system is too narrow. So we have resilience, we have people-centeredness. It's like when people think about the health system, they still think about a hospital, or they still think about primary health care. Can we conceptualize it in a different way? But very important, not to propose a new framework. I think we are all overwhelmed by frameworks. So we were trying to see what are the new, and we didn't want to say like, oh, we are coining a new framework. No. We wanted to be humble and say, we need to change differently, but not new frameworks. All at the end, we came up with a graph. So I was like, maybe we have defined the purpose. It looks more like a framework, but it's not a framework. It's more this idea that we are bringing together health systems with health security and the aim of healthy populations. But what is really, really important is this software and the values that you see there: trust and power, communities and right-based approaches, cross-sector engagement, and transnational impact. So what we learned with COVID-19 is that we can learn from other countries and that we haven't done this sufficiently. Here I want to say, I don't know if you've been to different meetings in Berlin or the latest WHO Assembly, everything is about trust now. So I'm very happy that finally people are paying attention to it, because I did my PhD 20 years ago on that topic. And for me, it was my favorite paper from my PhD, and it's the paper that is least quoted. So it was because there was not much interest at the time on trust. But I think we really need to understand what we mean by trust. And it's a complex concept, and it happens on different layers. But for you to be aware that trust is really becoming a fundamental concept in all our work. And when we looked at the report, here I'm going to leave it to you to have a look, but we're focusing a lot here on the actions that are needed in terms of making sure that we have strength, that our health systems are strengthened, and we focus a lot on governance, you can see there. And one that I always like, that we don't know how to do yet, is how to invest in effective leadership. So we do know from the pandemic that leadership was key, but how do we make sure that we have leaders, that they listen to the science and they act promptly? So that is difficult to find recommendations for. So the key recommendations for that report, I'm thinking here more for the workshop when we discuss indicators for health systems. I think we could still do better. Emphasize the commonalities between countries, although we always say that context is crucial, and invest in local research. So these were the key, and through a co-production approach that I will say a bit more. Now, very quickly, my approach to health systems, I said, will say a bit. So it's been always about breaking the silos, and I think I managed to also make this argument after 20 years of, I think I was 15 years at the London School of Hygiene of working in different projects. I think at the end, I think now I have a narrative, but at the end of the day, it was also the fact that we have short contracts. Like I was always doing 1 year, 2 year contracts. So I think I'm making it sound now very nice, but it was not really true. It was more jumping from project to project, and then at the end I said, I'm breaking the silos. But so I need to be a bit honest. I mean, that came 15 years later. Like when I went for the position here as a professorship, I didn't tell this story. I was like, all my career, I knew I wanted to break the silos. So anyway, just to say that, it's important to do health systems research on infectious diseases and NCDs. Important to do low and high. London School of Hygiene, some of you are aware, it was quite separate in terms of those who do high income and those who do low income. And I always kind of learned much more when I was doing both. Integrating different parts of the system is very important, and also integrating across sectors. So you can see there, we're looking at the vulnerable conditions, universal health coverage, but also social protection, which tends to be outside the health system. More breaking the silos. Here's the local, national, and global. I started working at the local level, interviewing patients. My background is I'm a sociologist, and then I did public health. So first, I wanted to talk to patients, listen to them. Then I moved into the meso, and then I wanted to go into the global sphere. And once I went to the global sphere, I realized that most people that work on global health at the global level, the governance of WHO, have never spoken to a patient. So these kind of interactions are also very important. And if possible, as I said, contribute to theory. Although in public health, there's not so many people working in this field, but I think it's important. Like in my case, I work out on governance, and how do we find new ways of conceptualizing trust, governance It does take much more time. Maybe to write a paper, it takes you 2 years. So I don't recommend it to everybody in terms of a career path, because you would only have a paper every 2 years, but it's also important to invest in this type of work. Okay, so I think I'm going to go a bit faster. I just wanted to give you an example now of how to influence policy. So I had the privilege to work on the independent panel. Has anyone heard of the independent panel that was asked by WHO to do an evaluation of the response? Yes, some of you, yes? Okay, for me, this was the most exciting work I've ever done. That was during the pandemic. Member states asked WHO, please do an evaluation of the response. They set up a committee with the co-chairs being Helen Clark and Madame Sherleaf, and then they wanted a secretariat to do all the research. So that was me leading the team of around 30 researchers all over the world, and it was the best experience ever. So they were going to present a report to the World Health Assembly, and I was behind the scenes doing the research. And what we produced was a chronology of the COVID response. So we had to do an investigation of what happened every day. So it was not whether the origin, that was not our remit. It was to find out who had made mistakes, what delays were there. And you can see there, this is available online. We had each day, hours, real evidence, and what the different actors did. And I was learning a lot from the policymakers. We released a previous report saying who was to blame, and then we had the final report based more on the recommendations, because we were more interested in the recommendations. And by who is to blame, I don't mean like if it was WHO, but we were saying there were delays by WHO, there were delays by China, there were delays by all the remaining countries. So nobody was happy with the report, because the blame was, in a way, was shared. But we wanted to move into what do we do next. So we produced the, So I was also responsible because I wanted to do a national response. Although we were focusing on the global, I wanted to do an analysis in countries. And this was excellent experience where I had the chance to talk to people, experts, academics in 28 countries. So you can imagine we only did this in 9 months. So it was nonstop talking to people, interviews. And here, I'm not going to go into a lot of detail, but we came up with some of the issues in terms of what to do in a crisis, what do you need to activate, adapt, preserve, and reduce? And above all, during a crisis, you need to learn and adjust continuously. But there you have details of all what we learned from the 28 countries. Above all, the countries that did well, what we saw is, although I have to say, for every time we found like a key aspect or theme that we thought it was fundamental, for example, key experience on pandemic preparedness. If they have key experience, if they have plans, they tended to do better. And then suddenly, we have Mexico as an exception, where they had beautiful plans, they had experience, but then the leadership decided not to implement them. One tick off. So it was kind of very difficult to say what were the key reasons. So we were giving some aspects that really we thought that worked. And again, just very quickly, leadership was key. And I spent a lot of time talking to key leaders. Like I was in New Zealand, listening to Jacinda Ardern's approach, and it was like really trying to other leaders in Liberia, and it was just fascinating to listen to how they approached it. And above all, the key aspects that were coming were leaders that they were being humble, they were listening, they were able to recognize mistakes, and they were avoiding groupthink. These are the leaders that did better. And they were willing to as I said, to acknowledge mistakes. And in some cultures, that would be impossible, or it would also be very difficult in terms of saying, okay, I've made a mistake, because then there would be legal consequences also. But above all, there was this kind of leadership that was emerging. And then what we know in terms of health systems, we know that the financial crisis affected a lot European systems. We also know that those countries that trusted more in science tended to do better. And then in terms of, there's many other issues, but in terms of one that stood out in many countries is that most countries introduced measures, but those countries that introduced measures and gave financial support to populations to be able to implement those measures, they did much better. So it's not only stay at home, but we're also going to give you money so you can stay at home and you can fulfill the requirements that we've been asking for. Now, very quickly, we've done several, from the work in the independent panel, we did several papers, several recommendations. And here, I just wanted to highlight that in the time of crisis, it feels a bit like you are reacting, but now what we need to work is what is behind the iceberg. And what we have there is to prepare and maintain our systems, but above all, when we discuss it, it's not going to work, health systems resilience, unless we transform our societies. And I mean, this is a bit outside the health systems that we do, the work that we do, but that's why I'm saying we really need to think differently about health systems, because if you see there the key recommendations, we need to build equitable societies and shift mindsets. I think more than ever, this is really difficult, but we really need to think as health system researchers and also in public health. In public health, we do campaigns all the time. We need to think a bit more outside the box. Long-term social protection measures and health promotion. This is the key one that nobody knew how to enforce this one. Informed, responsible leaders and effective coordination, and a whole of society, whole of government approach. And do I have 4 more minutes, Tim? Okay. Thank you. Okay, so this, one nice thing about this work, more in academic sense, when I took the position, everybody said to me, well, forget about publishing anything for 9 months. And I was like, of course, I mean, I'm contributing to the report. This is not academic work. But in the back of my mind, I was like, if we do things differently, why don't we provide and at that time, I think COVID showed that academic advice was very much appreciated. So I thought what I'm going to do is behind the scenes, I'm going to try to do all these papers, talk to the journals, submit, and then we ended up with a key paper in the Lancet, key paper in Nature Medicine, and 10 in the BMJ. So then now it's considered like one of a very successful way of doing a report with evidence, but I said to Helen Clark, I'm never repeating this again. I mean, I was like, it was so difficult because the Lancet would turn down our papers, and then it's like, oh, they're about to publish, and they were like, you have to release this in the form of reports, and I was like, no, give me 2 more weeks for the journals to agree. So that also we need to improve in terms of how long a journal takes to accept a paper. But this time it worked, but I don't think it would work maybe in another circumstance. So moving now to what I'm doing now on the Lancet Commission in 3 minutes. So after all this work, the report comes out. Angela Merkel says, really bold recommendations. Antonio Gutierrez says, we really need to implement them. The Biden administration is like, fantastic report. And I'm thinking, I think now I can retire because I'm never going to have so much impact in my life. Anyway, after that, being very naive, and then we found out that half of the recommendations have not been followed, have not been implemented. So then I was like, oh no, I cannot leave academia then. I need to continue doing some research. So just to highlight that what is very key, and that's why I admire so much Helen Clark, is that she said, although we don't exist anymore, because normally you do these big reports, and then that's it, you don't do anything else. But herself and some other commissioners said, we're going to continue every year doing accountability mechanism, progress that has been made, progress that has not been made. And every year, we're going to remind everybody. So this is every year and here. Transforming or tinkering. So that was trying, the world remains unprepared for the next threat. And here, very clearly, they highlight, this is what you've done. This is what you haven't done. So it's a way of, and governments, without acknowledging publicly, they would say, continue doing the work. Because although we don't exist, but it's an important way of providing account. And finally, 2 minutes. So when I finished the commission, and it felt a bit like, what do I do next? Because I'm never going to be able to. And then I thought one area that for me was very important was that when I was looking at all these indicators that they were saying which country was prepared or not, and you will see, oh, I don't have the slide here. Basically, it was ranking as the best prepared countries, the US and the UK. And we know that that was not exactly the case. So maybe, I think you will all agree. So the idea was that they were measuring the wrong things. And they forgot to measure all the things that in my commission were coming up. Leadership, coordination, trust. And then also the way that these indicators have been developed, they've been done in a very top-down approach. So really people from WHO or from the World Bank or top-level institutions telling what countries have to do. So this commission, what it's trying to do is do things the other way around. We're going to develop grassroots indicators. We're going to work with communities in 18 countries. And the idea is to work with them, to work with countries, and develop together indicators to be able to develop a toolkit for countries to implement. It's quite challenging. It has never been done. And I'm hoping we are successful. But if we are not successful because it's too complicated, I think at least we believe that the process will be useful. And on that note, I leave it there. Thank you.